by Dr. Aparna KS on the principles of lid reconstruction. She has completed her fellowship from Aravind Eye Hospital, Tirunelveli. Now, presently, she is working as a consultant oculoplastic surgeon at Chaitanya Hospital, Kollam.
Good morning. Lid reconstruction can be linked into solving a jigsaw puzzle because fitting the pieces will give a functional whole. But in order to retain the proper anatomy, we should know some basic principles of lid reconstruction, and we should have a thorough knowledge about the anatomy of the eyelid. So today I'll be discussing the principles of eyelid reconstruction. Various indications for lid reconstruction are lid coloboma, traumatic defects, burns, various tumors requiring resection, like that. The primary objective of this procedure is to restore the physiologic functioning of the eyelid, like maintaining vision, lid closure, mobility, tear drainage. Secondary objective is to restore the anatomic integrity, and final objective is to maintain best possible cosmesis. This can be attained by maintaining the symmetry between both eyes as much as possible. These are some of the cases which are managed by non-ophthalmic doctors from outside casualties. In the first two cases, there is lid margin involvement which is not taken care of, resulted in lag of thalamus and exposure. In the third case, you can see that it is medial to the medial canthus, medial to the punctum, so it is involving the lower canaliculus. But here the canalicular injury is not addressed, so results in lifelong epiphora for the patient. So during the preoperative evaluation, we have to look for certain factors which has role in deciding the choice of the procedure as well as the prognosis of the procedure, like whether it is involving upper lid or lower lid, whether it is a superficial or a deeper one, if it is involving the lid margin or a non-marginal tear, then size of the defect, shape of the defect, location of the defect, then elasticity of the lid, that in turn depends on the age of the patient, then condition of the periocular tissues and intraocular structures, etiology of the defects, and status of the lateral and medial canthus. And then we have to check whether it is involving the anterior lamella, that is skin and orbicularis, then posterior lamella, retractors and tarsus and conjunctiva, or if it is involving the involving both the lamellae, then we have to do a separate suturing for each lamellae. One important concept is relaxed skin tension lines or RSTL. These are basically the orientation of collagen fibrils. So whenever you are making an incision or doing suturing, try to orient it parallel to the RSTL. This will help to minimize the scarring. Another important concept is line of maximum extensibility or LME. It is basically the increase in length of skin under pressure. So whenever a wound is healing, the maximum tension should lie parallel to LME, that is, it should be perpendicular to RSTL. So the wound should be parallel to RSTL so that the wound tension will be parallel to LME. There is one exception in the lower lid. When we are making an incision in the lower lid, we have to make it perpendicular to the RSTL, because if you are making it parallel to the RSTL, it will be parallel to the lid margin. So when the wound is healing, there will be contraction of tissues that may result in lag of thalamus and malposition. So in lower lid, we have to make it perpendicular to the RSTL, and in remaining position, it is parallel to the RSTL. And before starting suturing, we have to thoroughly clean the wound and make sure that we have removed all the foreign bodies, and remove the tissue only if it is devitalized. Try to preserve normal tissues as much as possible and use the smallest caliber sutures possible, and make sure that the wound edges are not overlapping, but it should be in an everted position. This we can make sure by taking the loop such a way that in the superficial part it should be narrower and the deeper part of the loop should be wider. And if it is a round defect, convert it into an elliptical shape, and there should not be any tension or pulling effect on the suturing. Whenever there is presence of orbital fat. It is an indication for exploration of the levator muscle and aponeurosis, and we may have to repair the levator aponeurosis if it is lacerated. But during suturing, you should make sure that you are not involving the septum, because if we are suturing the septum, there will be vertical shortening of the septum that can result in lid retraction. If it is a smaller defect, we can approximate it, but if it is a larger one, we may have to take flaps or grafts. Flap is basically a tissue with its own blood supply, and graft is a piece of tissue without a blood supply. So in general, if one of the lamellae need to be reconstructed, we have to use a flap, and the other lamellae can be replaced either with a graft or flap. For anterior lamellae, the graft or flap should be the graft should be matching with the color of the surrounding tissues, and posterior lamellae should be with a tissue which is smooth and capable of producing mucin for lubrication. Donor tissue options for anterior lamella include skin from the postauricular supraclavicular area, medial side of the upper arm, in children from the groin area, then lax upper lid skin that we can use. Posterior lamella options are nasal mucosa, buccal mucosa, palatal graft, conjunctival and tarsal graft. Full thickness defect we can classify into various types like small, medium and large. For young patients, it is small means less than 25%, but older age group it is more than 30% because their skin is more lax. And larger means for young patients it is more than 50%, but older individuals it is more than 60%. And for anterior lamellar defect, if it is smaller, we can allow healing by granulation as in a lysis vere technique. Then we can go for primary closure, mucocutaneous flaps or grafts. Then full thickness defect based on the size and whether it is upper lid or lower lid, we have different options that will be discussed by the coming speakers. Basically for upper lid, we have to borrow from the forehead or lower lid, and for lower lid, we have to borrow from the cheek or forehead. So my take home message is the lid reconstruction should be a customized approach for each patient, and we have to adhere to the logical principles and follow a stepwise manner, and if needed request assistance from the subspecialist. Thank you.
Thank you, Dr. Aparna, for that comprehensive coverage of the